It's my personal pleasure to introduce the moderator for the next panel, Susan Lynch, who is the Civil Division Senior Counsel for Elder Justice. She is the leader of the department's National Nursing Home Initiative. She has been prosecuting healthcare fraud cases and nursing home cases for over 20 years. She is a nationally recognized leader on nursing home abuse, and she is basically the spine of the department's nursing home efforts. She coordinates closely with federal agencies, ranging from HHS as well as ACL, as well as with state Medicaid fraud control units. She has done hundreds of trainings in order to teach people how to investigate nursing home cases. And so we are incredibly grateful that she has taken the time out of her schedule to lead this panel, to teach us a little bit more about nursing home abuse and what we can do about it. So with that, thank you very much, Susan.
And thank you, Andy, for your leadership in elder justice in this summit and in the long-term care space. Critically important work. Well, welcome everyone to the last panel of the day. We're going to be focusing on identifying and investigating abuse occurring in long-term care facilities. And we're basically going to focus on three basic areas. One is how facts and circumstances in nursing home cases can literally be crimes. A nursing home can be, with the right facts and circumstances, a crime scene. Secondly, we're going to look at the best practices to identify, investigate, and report in long-term care cases. And then finally, the really critical importance, a theme that's been raised throughout the day, of important partnerships and collaborations. And so law enforcement collaborating with EMS and long-term care ombudsman is absolutely critical. You know, I would say as we go through this presentation today, we need you, law enforcement, to partner with us, Department of Justice, state, EMS, ombudsman, to really bring to justice those nursing homes and their owners that are providing grossly substandard care to residents. And those are residents, these are people, our mothers, fathers, sisters, brothers in our communities. I am super thankful to the panel who I'm going to introduce in some detail here so you can get a sense of their wisdom and their background for working so hard on putting this panel together. I'd like to start with Captain Nicole Nappy. Captain Nappy leads training for EMS in Baltimore County, Maryland, a very busy and innovative jurisdiction. She's a nationally registered and Maryland paramedic and has been in the field for decades. Captain Nappy has been selected to serve on many, many committees in the county and the state, including deployment, research, and development. And Captain Nappy is an instructor in EMS at Carroll Community College. And of note, she was my instructor when I was going through the program many years ago. And I can certainly testify to her commitment and dedication to teaching and as a provider. Second, Officer Ron Johnson serves as the Elder Vulnerable Adult Abuse and Neglect Liaison for Baltimore County. Prior to his leadership role there, Officer Johnson was a patrol officer in Pikesville, Maryland, another very busy precinct for over 14 years. And his current duties include many of the things we've talked about today: training in the police academy, receiving all the elder abuse reports for the county, and doing a lot of training in the senior centers. And Officer Johnson's going to offer a number of best practices for you all as you consider these cases. And then finally, National Ombudsman Program Coordinator Bev Laubert. She has served as an ombudsman in Ohio for 33 years prior to her leadership role now at the Administration for Community Living. And 26 of those years, she was the state long-term care ombudsman. She also spent a year in the governor's office, in the cabinet, in the Department of Ohio, in the Department of Aging. And I have reached to Bev a number of times for her counsel over the years. So with that, let's turn to the agenda for today. So we're going to talk about abuse and neglect in nursing homes. What does it look like? We've talked a lot about it in the community, but we're going to focus here on nursing homes and other long-term care facilities. What are some of the relevant state and federal laws and regulations? I'm not going to teach a law class here, but I do want to focus on how some of the facts and circumstances that you might see really could be crimes or civil cases for that matter. Again, talking about the important partnerships with EMS and of course with Ombudsman. And then the critically important issue for you, which is some best practices in identifying and responding to some of these elder abuse cases. We'll end with some learning in action. We'll look at a couple of scenarios that you may encounter in the field, and then we invite your Q&A. So please, as we go through, maintain your questions so we have them at the end. Okay, so it's late in the afternoon. I'm going to do a little audience participation here. So show of hands. How many of you have been on a call to service where you've been in a long-term care facility and felt that something was just not right, that maybe there is a quality of care problem? How many? Okay, we've got a good number. So as Officer Simeone said, it may be that gut feeling, right? You get that sort of gut punch where you say, something's wrong here. And it may be something that you see. It may be that the individuals there are looking like they might be under the influence of some sort of antipsychotic medication. Or it may be that people look like they're thin or that there's not enough staff. Maybe it's what you don't see. There's not enough staff in the building, or maybe there's a smell. And I think, in these cases, it's important for us to investigate, to go further than the beautiful furniture that you may see in the lobby and figure out what's going on here if in fact there's a problem. So what type of elder abuse could you see in a nursing home? Well, obviously we've already talked a lot about physical abuse. You could see bruising, you could see wounds, you could see burns, any number of things could be there. You could also see evidence of financial abuse in a nursing home, and this might not be as direct as you may see in the community, but you might see that somebody doesn't have what they should have, their clothing. They might not have, their glasses with them, or their pain patch was stolen, or maybe in fact, some of their items are stolen. And this could be abuse by a staff member, by another resident, by a family member, or somebody coming into the facility. So that's important to keep in mind as well. There could be psychological abuse, and what would that look like? That would look like when you come in onto the scene, you see an individual who's looking away, who's frightened, or maybe somebody who is very concerned about who else might hear them in the room, and so they're a little bit nervous and a little bit scattered. Perhaps the person, is concerned about being photographed. So this is another issue. Sexual abuse, in 2018, the Human Rights Watch did a really horrific but very poignant report on sexual abuse in nursing homes, and it is something that occurs. It occurs, staff on resident, resident on resident. You may see bruising on the thighs. You may see that somebody has an STD, or that they're very anxious, and so that is also something that you'll see. And then neglect. And Dr. Mosqueda talked a lot about what you might see in the case of neglect. You may see pressure ulcers, you may see emaciation, you may see somebody lying in their own waste. These are examples when you arrive on scene of serious neglect in a nursing home. And as we'll talk about, nursing homes are skilled nursing facilities or nursing facilities. The federal or state government, and both in many cases, are paying these places to basically care for people who need the care. And in that case, you have yet another sound today. And in that case, they should be providing the quality and skilled care. So I'm going to talk about the types of problems you could see in a nursing home when you arrive on the scene, whether you're called to the scene or first on scene, that could lead to a federal or state criminal case or civil case. The first thing is staffing. Do you have an adequate number and skill level of staff? Do you walk into the facility in the middle of the night on a call and there's like one person sitting there on their phone? Do you have enough people to take care of these individuals? And do they know what they're doing? Are they there with sufficient staff with knowledge for the resident acuity? Inadequate supplies. It's pretty shocking sometimes to run a call and to find out that there's not enough, food or gloves or medicines to run this long-term care facility for these residents. Or terrible physical plant conditions. You pull up to the scene and you see that, there's a hole in the roof, or it's the middle of the summer and the air conditioning isn't working in one unit, or it's the middle of the winter and the showers are freezing. This is leaking roofs. And we'll go through one example that's terribly shocking. That was a criminal case in the state of Georgia, to give you an idea of, why that gut check when you walk in and you think, oh, something isn't right here. What might be going on behind the scenes that you don't see, but it will kind of validate that feeling that, something may not be right. Overuse of antipsychotic medications. Do you see residents lining the halls looking like they're kind of not really with it, or the person that you're being called to? Failure to supervise violent residents. I mean, my personal story, and I was stunned. My godmother was in a nursing facility, large chain that shall remain nameless, and I was there visiting her from out of state. And I saw we were in one of those situations where, we're kind of all sitting in a big area. And I'm sitting with my godmother, and there's these two residents, and one resident hauled off and smacked the other resident, an old woman, right in the face. I thought, oh my gosh. And then I looked at the staff, and they reacted like, oh, just another day at the office. Well, the first thing I did when I got back to Washington, D.C. was try to get her moved out of there. So again, failure to supervise violent patients. Another thing that you may not see, but you may learn about or hear about, in the community, is a compensation structure in this facility where you got a lot of really sick people and not enough staff, right? So, I mean, it's a place where they're trying to maximize revenues by bringing in really sick people and then not enough staff to care for them. And finally, failure to investigate resident or family complaints. And so you may hear a family member say, gosh, I've been calling this place about this problem and nobody did anything about it. So what does that mean for the individual, the resident in our community? They can be malnourished and dehydrated. I mean, nothing is sadder than having a resident sitting in their chair and the food is right over there, but they can't reach it because they've lost the ability to, use their limbs. They can't chew and swallow or they'll choke. Well, sure, somebody brought the tray in, but nobody fed them. Pressure sores, we've seen just horrific examples of that, lying in feces and urine. Residents who are filthy and infected, and to Dr. Mosqueda's point, maybe they're filthy in parts of their body, but that's certainly not okay. Wrong or too little medication. A lot of times, if you're talking to somebody and they're in a lot of pain, that's not okay. You're not supposed to be in a skilled nursing facility and not being given appropriate pain medication. And repeated falls and fractures. A person is a two-person assist to move from bed to wheelchair, for example. There's no way you've got one CNA for 50 residents. One person moves that individual, they fall, and this is happening over and over. And you learn in the community, as Captain Nappy will say, and others, the facilities where these problems occur on a regular basis. So elder abuse in a long-term care facility can be a crime. And again, I'm not gonna teach the law here, but just to say, some of these things that I've described can really turn into, and I'm giving the example of the state of Maryland here, into some serious situations. I mean, if in fact you're intentionally causing or attempting to cause serious physical injury, abuse, sexual abuse, that can be assault in the first degree. If you're physically harming somebody, again, or attempting to do so, that can be assault in the second degree. All the way down, I'll focus on reckless endangerment in the state of Maryland, engaging in conduct that creates a substantial risk of death or serious physical injury. Well, some of those things I've talked about earlier could fall into that category. And obviously, individuals could be liable up the chain of an organization if, the appropriate elements are there. So what I do in leading the National Nursing Home Initiative is look at civil, basically at running the initiative where the department looks at civil, criminal, and civil rights cases. We bring our cases for grossly substandard care under the False Claims Act. It's a federal fraud statute. One example that I'm going to talk about here in the context of Hurricane Katrina, a hurricane, not Hurricane Katrina. There's too many hurricanes going on here. Is under the National Housing Act, and the department looks at corporations and individuals, right? I mean, the corporation has liability, but the individuals oftentimes are the ones who are making the decisions. Criminal actions. So healthcare fraud can be a criminal action in the context of providing grossly substandard care, and I'll talk about an example of that. Tax violations, what they say, sometimes it's the taxes that get you. Well, in a lot of these cases, we have healthcare fraud, that is to say grossly substandard care, combined with a tax violation. Somebody's not withholding taxes, some employee taxes. Somebody is withholding them, but not paying the government what they're due. And then finally, the Civil Rights Division under what's called CRIPA, the Civil Rights for Institutionalized Persons Act, that looks at state and local nursing facilities and other types of facilities that are providing poor care or in some way not caring for the rights of individuals. So two examples. One I'm just going to describe here, the civil case example briefly, just to give you an idea that sometimes if you see something, it can be part of a federal civil case. So many of you recall the situation in the context of the Hurricane Ida, which was the Hurricane Ida in Louisiana. This is called the Bob Dean case. You remember those awful images on TV with residents being, wheeled across the street with their hands over their heads and in significant pain. And so this was a really big case and a really big problem. What happened here is last year, the United States filed a complaint under the National Housing Act. So an act allowing us to have jurisdiction over this because of the fact that to get one of these federal housing loans, there had to be, in mortgage insurance, there had to be certain contracts and agreements signed, which basically said the facility was going to use the funds for, guess what, to care for the residents. And so in this case, in the context of Hurricane Katrina, what was supposed to happen was this individual, Bob Dean, and his affiliated companies were supposed to retrofit some of these warehouses for purposes of evacuation, which, if it happened as it did, would have been a good thing. But what ended up happening was this owner, Bob Dean, took over $1 million. And rather than doing what he was supposed to be doing to care for the residents and creating sanitation and food and those types of things, siphoned all that money for the personal use. So even after these poor residents were, dragged across the street and all of that type of thing, when they actually got to their destination in these warehouses, they didn't have the basic needs that they had. So if you're responding to something like that, and interviewing folks and taking that information down, that can be part of a larger federal case. The next example I want to talk about is the Hauser case in the state of Georgia. And I'm going to go through a little bit of the evidence here for purposes of identifying what you might see in an investigation, what you might look for, and also to show you what sometimes is going on behind the scenes of those gut check situations where you say something's wrong here. So this is a National Enquirer article. They actually got the facts right here. This individual, George Hauser, owned 3 or 4 nursing homes. He was interestingly a Harvard Law School graduate, owned a bunch of nursing homes, and essentially made them circle the drain in a short period of time. We had evidence here, we felt like, I should say that the brilliant prosecutor, Glenn Baker in the Northern District of Georgia, had evidence of especially egregious care. What makes a case criminal? These factors, right? Systemic and widespread problems, which I'll show you, evidence of real harm to residents, and a pattern and practice of this behavior over many years. So what happened? The facility is supposed to be taking care of residents, but because the money wasn't going where it should have been going from the federal and state government to the facility to care for residents, it was going and being siphoned off to this individual. They were turning off the power. They were turning off the gas. They were turning off the water. They weren't providing money for food. So sad. They had testimony in this trial that hungry residents watched the Cisco food trucks pull up. And then, of course, they turned around and drove out because when the gentleman who was delivering the food went to the front desk, they were like, oh, well, the bill hasn't been paid. Bread and milk wasn't delivered. Trash was like sky high outside the building. And this was happening in the US in 2013 and 14. Pest control services were not being taken care of. And those things fundamental to care of the residents. X-rays weren't being done or read. Lab services weren't being pulled. So, if you go, and I'm sure Captain Nappy will talk about this, and I'm sure others may as well. But when you go and ask for somebody's medical record and like there haven't been labs pulled in a while, that might be something to think about. No fire alarm services. So what did the investigators do here? Really brilliant. They said, okay, these residents look really thin and really sick, and my gut tells me something is wrong. So they looked at, over the course of time and through subpoenas and other vehicles, what is the average amount spent on residents per day in the state of Georgia for nursing homes? And it was $5.60 per day. So that's sort of interesting. I mean, that's pretty low. But this facility, this Mount Berry facility, which was one of the facilities that was the subject of this trial, was spending $1.83 per day per resident. I mean, one cannot get a tall Starbucks for $1.83 a day. That's a problem. What else was happening? Well, it's interesting, you look at some of these documents, and I don't know if you can actually read that. This was from the public trial, but there's information here, as a prosecutor, when you get these types of documents, you say, wow, we've got something here. Things like, we are in serious need of money. We need money today. We can't give insulin after this afternoon. I mean, this is a crisis, right? This is happening. And maybe when you go to these facilities, if you see some things, something like this could be going down in the background. This one is particularly interesting. We have ceiling tiles and roof tiles leaking on residents' beds. Bring money. And again, this is Georgia. It gets warm in Georgia. So where is the money going? Drum roll. Drum roll. It's going there. Now, what's that? That's a mansion that this individual, George Hauser, was building for himself and family members. Interesting. So while residents are living there, we're getting information like this. So again, as you're investigating, if you can match that type of evidence to these types of pictures, you got yourself a good case. So what did this guy, George Hauser, do? He is what my daughter would call a dumb criminal. So he was doing depositions in other cases, and they asked him questions. And this was all before the trial case. And they said, so asked him some question, and he answered related to government funds. I was like a kid in a candy store. Beautiful. What else was he doing? Well, there were payroll issues in this nursing home. Employees' checks were bouncing. And so this is pathetic, but think about this. What was happening was, on a Friday, he knew he had, pick a number, $60,000 in the bank to pay the payroll checks. And he really had written $100,000 worth of checks. So he gives people their checks every 2 weeks. The people take the money and run to the bank. Why? Because they want to be that first $60,000 to get paid. Well, what's the problem with that? The residents are now unattended. And so there's a race to the bank. The banks are not liking this, so they're stopping, to cash these checks. And we've got a system here that's obviously not working well and not good for the residents. In addition, and this is really sad, he was stealing from the resident trust funds. And Bev may talk about this, but a resident trust fund is about $1,500 or so, depending on the situation, that residents have so they can do basic things like, buy personal items. He was stealing from that to pay for payroll. So what ended up happening to this gentleman? He got 20 years in federal prison, 3 years supervised release, paid back about $6.7 million in restitution to Medicare and Medicaid, and about $875 to the IRS. The district court judge, in commenting on some of these, the situation of some of these residents in this federal criminal case, said the care in this home essentially was cruel, atrocious, barbaric, inhumane, and uncivilized. Right. So what we want to do is stop this from happening in our communities. And so with that, I'll turn it over to Captain Nappy.
All right, here we go. Can you hear me now? All right. So as EMS, we play an intricate role with law enforcement. We want to encourage the relationship with EMS. It's important for us to all work together. So I'm going to talk a little bit about how we all fit together in this component. So first off, we have a unique situation. We're in these nursing homes pretty much daily, and some nursing homes 2 or 3 times a day for 911 related calls. So one thing we want to make sure that we do is we identify if there's a concern. We want to take that concern and investigate a little bit if we see something that may be out of the ordinary. And then our ultimate goal is to report it to police or also outside agencies such as Adult Protective Services and social services. So why we are actually usually the first eyes on the patient or the first eyes in the facility. 9 times out of 10, when we're called for a 911 call, it's typically us going in for a medical case or us going in for an injured subject. And then we identify the circumstances and we may end up calling for police at that point in time. So what happens in that short period of time? There could be some cover-ups that could happen. So we want to make sure as EMS that when we walk in an establishment that we look at that scene. And I'm sure scene size up is not a new term to any of you out here, but the goal is the same. We want to make sure that we assess the environment and look at the surroundings. as we stated earlier, how many people are on staff? Does somebody come in the room when we're entering the patient's room? Is there somebody by their bedside? Are they giving us paperwork? Are they giving us correct paperwork? There's many times, and I can attest on my own, there's many times I'm handed paperwork that doesn't belong to this patient that I'm actually taking out, and this happens quite often. Our assessment of the patient is crucial. We want to make sure that we do thorough assessments, not only on the complaint, but anything else that we might notice. And a huge component of this all is documentation. We also know that you all are very thorough with documentation. We have to provide that same documentation. So things we look for, so physical abuse and or sexual abuse might be a little harder for us to determine. But as far as physical abuse goes, we want to look for any unexplained cuts. Same thing with a child abuse case, could be the same thing with an elder abuse case. Fractures healing in different stages, wounds, bed sores, bruises, welts. Are they undernourished? Are they dehydrated? Are they receiving the care that they are there to receive? So any unexplained sexually transmitted diseases, as I said before, we may not necessarily know that, but one thing that we would do is we would look at their paperwork, look at the medications that they're on, look at the sheet that they give us that are they getting their medications as they're supposed to? And then just, is there anything going untreated? So the psychological aspect, as you've heard earlier today, this also may be a little difficult for us because we're just meeting some of these patients for the first time. So we don't know their history, we don't know their background, we don't know how they normally function or how they normally act. So is there a family member there? Could we ask, is this different? Because that is a huge component of any unexplained psychological behavior that could be going on. Do they appear withdrawn? Do they appear confused? Are they angry? And we also want to look at the caregiver and the staff member. So a lot of times, how many times have we been in a nursing home where we saw a staff member get aggressive with a patient? Maybe not physically in front of you, but how about verbally, or be very frustrated with a situation that's going on? So these are things for us to take note and definitely document. Observe that demeanor. So neglect or self-neglect, we look at hygiene. Also look at the environment that you're in. Look at the room that you're in. Note any smells as we walk through that door. We want to see are their bed sheets clean? Are their bedside tables clean? Are they bed confined, and do they have their nightside table next to them? Do they have water there? Do they have access to any of these things? Is there a call button or their alert button? Is that next to them? Is that within reach? So these are things for us to note. And that's not even that's just the physical aspect and looking at the whole picture. But then it comes, talk to the patient, physically talk to them and ask them, how are you doing? How are things going? We noticed you didn't have this next to you or that next to you. Do you wear glasses? Do you have hearing aids? Are those available to you? Can you reach them? So our documentation becomes a vital part of our care. So not only does our documentation get passed on for continuity of care at the hospital, but it can also be used for criminal proceedings. Our reports are pulled constantly. It is important, and I can't stress enough, and for you to stress to your EMS providers, talk to them about document certain things in the scene. If you're going to put something in your report and they're seeing it too, or they verbalize something to you, that should be going in their report. Anything that could be vital for the history of this case, we want to make sure that we're using. If there's any direct quotes from a resident or a family or caregiver, we want to make sure that those are in those PCRs or patient care reports and that they are in quotations. On our end, we always mean objective. We don't necessarily put subjective information in there. We want to make sure that we just document the facts. So in some abuse cases, some important issues for us to consider is the consent to transport. So we have the same laws that you do. We have to receive consent to transport. Just because the facility called and are requesting a transport, we still have to get consent from that patient. We can't just take that patient on their will. We can look to the power of attorney if they are present or they're available to be on the scene. We do require paperwork. If they're stating that they're a power of attorney, we do require some type of documentation to prove that. And then our reporting. So our reporting goes to multiple agencies. We don't just call law enforcement. We follow up with social services and we follow up with APS. So these are phone calls that we have to make on our own, as well as contacting law enforcement for a report. We also, if we are transporting this patient, so we also let the hospital know, but that doesn't count as any type of reporting. The hospitals are under the same laws where they also have to report. So now these agencies are receiving at least three separate phone calls: the hospital, EMS, and police. And another issue that we run into are frequent callers. So we had mentioned that a little bit earlier today, that there was someone who was frequently calling and hanging up from 911. It was somebody with dementia. We get these frequent calls all the time. And one thing that we see is people ignoring them and just saying that, oh, it's the same thing. They're just calling, they may have fallen, or they want their glass of water, or they want this, or we get these calls in nursing facilities too, where the resident will call us because they want to be moved, or the staff isn't coming in the room. They want a glass of water. These calls actually do physically come from the nursing home. So you need to look into us as providers and as first responders, we need to look into these calls for service. Is the nursing home not providing what this patient needs? And then some different agencies might have mobile integrated health. We are advancing our mobile integrated health at this time. Currently, we have what's called an eye care system. And our eye care system is just a special unit within our department that if we see these instances, whether they're in private residence or in nursing homes, we report them over the eye care system, and their job is to close that connection with other agencies. And then we're actually going to talk about some of this through our scenario. And then just to reiterate, with our reporting guidelines, and that comes with our certifications as well as with the guidelines from the department, we do report to law enforcement. We may end up calling you out to the scene, and it's specifically for what we see. But then we also have to follow up with the Department of Health, Department of Aging, local Ombudsman program, and our health department.
So thank you, Captain Nappy. Officer Johnson, over to you.
Thank you. Again, my name is Officer Ron Johnson. I work for Baltimore County Police Department. I am the Elder Abuse Adult Neglect Liaison for the department. So essentially what I do is I tie all of the stuff that we have in our department, such as Captain Nappy. I tie everything together. So a lot of stuff comes through me. So my phone rings quite frequently. I'm getting called right now.
Mm-hmm.
But yeah, so everything that there's a question of any abuse case, any neglect case, anything like that, a lot of the stuff comes through me. So I have to kind of be on my toes, and I've been doing this for almost 3 years now. And, like they said earlier, some of us, we know we're supposed to be here. And I feel like this is something that I know this is what I'm supposed to be doing. So we're going to identify, investigate, and report elder abuse and neglect. So the first one, identifying elder abuse on a call for service. The first one is going to be unexplained bruising. That's if, the nurses can't tell you how they got that bruising. They themselves can't tell you how they got that bruising. Now, there's also other stipulations that go along with that, like if they have medical conditions, braille or skin, thin skin and stuff like that. So again, this is all stuff that you have to kind of put into your report and we'll figure it out later. The victim will not look at you and they'll look to their caregivers for answers. A lot of times they'll do that because they're afraid of retaliation or they're afraid of getting assaulted again, or there's something else. Again, not one of these things would indicate elder abuse, but when you start putting things together, that's where we as law enforcement, we use our spidey senses and we start putting things together. And then the fear of the retaliation. Steps to take when responding to a call for service for elder abuse. Now, again, this is just for Baltimore County. I would assume it would be kind of standard for all, but you can throw in your things here and there. The first one is interview everyone. That is really big. Interview everyone that you see. Everyone, every person, anyone that's ever come in contact with your victim. If they're sharing a bed with someone, then interview that person. Interview their nurse, and then interview their nurse's nurse, and then the interview that I can't stress to you enough. Interview more people. Video surveillance is pretty big in our county for our prosecution wise. They like to have at least something that can kind of corroborate a story with video surveillance. Now, obviously, they can't have them in the rooms, but a lot of our facilities have cameras in hallways or entrances coming in. If they say, this nurse was working at this time, and if we have them coming into the building and that nurse is like, no, I didn't work that day. Well, we have you on video coming into the building. It just kind of builds our report. And then speak to the victims alone. That's not always easy, but we try to get them alone because of they may be looking towards their caregivers and stuff like that, just so we can kind of put them at ease and we can kind of talk to them and kind of bring them down from whatever stress that they may have just gone through. And it's easier to pull things out of them when they're alone. Excuse me. Preparing reports for elder abuse, as we're all law enforcement, so we know everything starts with our basic report, right? So that's why we tell you, document everything. There's no case that you're ever going to solve that didn't start with a report. So everything you see, everything you hear, everything you smell, anything you can think of. Like they were saying earlier, if the place looks a mess when you first walk in there, document it. Now, I know our agency, I don't know if every agency, but most agencies nowadays are going to body-worn cameras, right? Now, body-worn cameras are an absolute godsend for cases like this because now not only do we have it in our report, but now we also have video evidence of it from the little camera that's on the side. So now not only are we painting the picture, but they're actually physically seeing that picture when it goes to court. And then like they were saying earlier about you go in it on nighttime and there's one nurse for 50 patients. We'll put that in your report. Make sure they see that on camera because all of that helps. Document the license number and for the facility. That's more so for me because I keep a tab of all these things. So if I see the same facility 67 times in 1 year, then I know I have to do a little bit digging into that facility. Documenting unlicensed is really big. There's a whole, and we'll get into that a little bit later about unlicensed facilities and stuff like that. I've actually shut one down, and I've only been doing this for 2.5 years. So it's, yeah, if they're unlicensed, document that as well. If your agency has specific units that are responsible for following up on these cases, make sure they get these cases. Don't assume that they're getting them. Actually send them to them, whether it be through fax, through email, through text message, pigeon carriers. Doesn't matter. Just make sure they get them. And don't always assume that the people responsible for the investigations are going to get them. And then contact your local resources. Like we have a bunch in Baltimore County. We have APS. We have Adult Protective Services, obviously. Then we have the Ombudsman program. I work very closely with them. Special victims. If it's a rape case, we have a financial crimes unit that handles all financial crimes. So if it's a financial exploitation, then it'll go to them and stuff like that. Key considerations for law enforcement in abuse cases in nursing homes. The first one is understand that some residents may have diminished mental capacities. We all know that. We all went over a bunch of the diminished mental capacities earlier. So we just have to recognize that and not think that just because they can't recall something that happened a day or two ago, we now know why they can't recall that. Just kind of piece together what they say. And if they're jotting things down, then take what they're saying and jot that down. Pull out the little snippets of what they're telling you, because at the end of the day, it's going to paint a bigger picture once you finally get all of the pieces. It's going to pull everything together. So if they're making random, statements and stuff like that, document everything. That's why I tell you to document everything. And then also, we have to remain professional. I've actually handled a couple of complaints about officers in nursing homes. I don't know how it came to me, but I was okay with putting out the fire about just remember that it's someone's loved one, and it might not, we're taught to be empathetic, right? So just kind of put yourself in that place. If that was your loved one, your mom, your dad, your aunt, your uncle, or something like that, just make sure that they're, be cognizant that it is someone's loved one, and don't just treat it like another call for service, because it might not be just another call for service. It might be something bigger, and you might be on to something small, but that might turn into something bigger. Important issues to consider. Okay. For us, I'm part of a coalition. It's called BC Rest. It's called Baltimore County Restoring Elder Safety Today. And what we do is we meet now on a bi-monthly basis. It's basically one person from each entity that Baltimore County has, and we're a group, right? We'll sit around on a WebEx and we'll talk about, what each person is going through in their respective departments. Like we have myself, Department of Aging, Ombudsman program. We have public library. We have AARP. We have legal aid. We have sometimes some of the prosecutors will come in, sit on some of our meetings, and we'll just kind of go over things and how we can each help each other out through some things that we have going on. And then reporting to multiple agencies, that's kind of what I do. So if your agency has someone like me, just make sure you're keeping them informed. And if that is you, just make sure that you are in the know of a lot of things, because I get a lot of calls about a lot of cases, and people think that I handle them. I don't necessarily investigate them. I'm just I have my hand in it somehow. Like, I make sure if it's a financial crime case, then I make sure the supervisor in financial crimes knows about it. Or if it's a case that happened in Carroll County, but it got reported out here, then I'll reach out to my resources in Carroll County and make sure that they're aware of it and stuff like that. So, and then this is all something that we're going to get to later.
Yep.
Is this me?
Mhm.
Nope. No, I went forward.
Yeah.
Okay.
So thank you, Officer. And Beverly, on to you on National Ombudsman work.
Okay. I have been so excited to hear so many people say ombudsman today. That's unusual in a lot of presentations I do. So I'm glad to hear that. So what I'm going to do is give you kind of the basics of what the ombudsman program is, how it's structured, and provide some examples of working together. So tell me, I'm doing the green button. Okay. Okay. Whoops. I went too far. Just back. Okay. So Arthur Fleming was a commissioner on aging when the Ombudsman program was created under the Nixon administration after Social Security, the Social Security Act and Medicare and Medicaid started in 1965, as well as the Older Americans Act, and more nursing homes were being developed and built because then there was a funding source, Medicare and Medicaid. For people. So what we used to have as county homes, poor houses often called, for individuals who needed care, couldn't live alone, became businesses. And soon after, as that development occurred, the administration, federal government, started getting complaints about abuse in nursing homes. So Arthur Fleming and others had the idea of creating an advocacy program for those residents. And I thought this quote was especially important for what we're doing here today and tomorrow. Our nation has been conducting investigations, passing new laws, and issuing new regulations relative to nursing homes at a rapid rate during the past few years. Remember, this was in 1976. All of this activity will be of little avail unless our communities are organized in such a manner that new laws and new regulations are utilized to deal with the individual complaints of older persons who are living in nursing homes. The individual in the nursing home is powerless. If the laws and regulations are not being applied to her or to him, they might just as well have not been passed or issued. So that's really why we're here, to talk about why it's so important for us to all be collaborating. And by working together, we're giving power back to those residents. You know, I was thinking there were so many great visuals today, and I don't have any great visuals, but I was thinking if we did a Venn diagram, the resident would be in the middle and the rest of us would all be around those residents. And we have to be working together for their safety. So the Older Americans Act authorizes the long-term care ombudsman. They're at the Administration for Community Living. The Administration on Aging Center is the Office of Long-Term Care Ombudsman Programs, where I work. We have 53 offices of state long-term care ombudsmen. That's every state, the District of Columbia, Puerto Rico, and Guam. All have state ombudsmen. There's a requirement that that the state establish an office of the state long-term care ombudsman headed by a full-time state ombudsman who does not do anything other than being the state ombudsman, who's responsible for this statewide office, and it is to be a unified office. We've heard mention of area agencies on aging today. Not all local ombudsman programs are in area agencies on aging. That is the majority, but the state ombudsman has the authority to designate local ombudsman entities, and those might be area agencies on aging. They might be legal service agencies. They might be, in Ohio, Easter Seals is one. So the state ombudsman makes that determination, and then also designates and certifies representatives of the office of the state ombudsman. So when you are seeing a local ombudsman who might work for an area agency on aging, might work for Easter Seals, they are accountable to the state ombudsman, even though they are employed by that local agency. So there are 446 local ombudsman entities. There are some states that are centralized. It's probably a detail. I don't know if that matters to you or not, but there might not be a local ombudsman in your jurisdiction. They might all be state employees. There we have several states that are centralized. So the state ombudsman employs all of the ombudsmen who go to facilities. About 1,800 staff in those programs and the state offices, and about 4,000 volunteers. Volunteers are important in the Ombudsman program. We consider them community extenders, helping us provide a regular presence in nursing homes and other long-term care facilities. And I should have said that. Ombudsmen go to any long-term care facility, assisted living, board and care homes, nursing homes, a variety. Some states also have ombudsmen helping consumers who get care in their own homes. Those are not federally funded. But with over 15,000 nursing homes and nearly 60,000 residential care communities, the reality about that regular visitation really varies around the country. So ombudsmen are advocates for residents. They are resident directed. They are not enforcers of the law or regulations for long-term care facilities. They support residents. They are directed by the residents. They have strict confidentiality requirements, conflicts of interest requirements, and so on. They identify, investigate, and resolve complaints made by or on behalf of residents that relate to an action by the long-term care facility, by public agencies, by health and social service agencies, that might adversely affect the health, safety, welfare, or rights of residents. We're very rights-based. There is a federal Bill of Rights, there are state bills of rights for residents, and ombudsmen are often the primary resource in helping residents assert their rights. They provide information and assistance. They make non-complaint visits to long-term care facilities. And I wanted to note that especially because as we were hearing some of the things that my panel partners here were talking about when they go into a nursing home, and especially the one that Ron mentioned about surveillance cameras. You know, the ombudsmen get to know the facilities. They are visiting them on a regular basis. They're handling 182,000 complaints a year or more. And then they're also doing these non-complaint visits. So it's possible that an ombudsman who's interacting with law enforcement or EMS might know that there's a camera in the facility, or that there are residents that have cameras in their rooms. And when I worked with our Medicaid fraud control unit in Ohio, one of the things that I would sometimes do was say, when I was making a referral to them for an investigation, I would say, I know that that facility has cameras, and I know a few residents who have cameras in their rooms. So that was a key to them to tell local law enforcement or their own investigators to quickly tell the facility to not erase any video while their investigation was pending. So sometimes that information that an ombudsman might have about a facility may be useful to you. Ombudsman also performs systems advocacy, policies, legislation, working with partners, Medicaid agencies, survey agencies, and so on. And thanks to Susan's effort, we've been trying to improve relationships and interaction with the Department of Justice, the HHS Office of Inspector General, Medicaid fraud control units, and state ombudsmen around the country in the last year or so. And it occurred to me in terms of systems advocacy, as I was listening earlier, a key factor, and I can't remember who the presenter was, but a key factor in one of the cases was that the individual wrote on the check she was giving to this woman what the check was for, drug treatment, whatever else. And it occurred to me, my kids, when they're 80, there won't be checks. So, you know, we need to be thinking ahead about, you know, maybe banks, everybody's doing online banking now. I make transfers to my kids, but I can't there's no note. There's no way for me to document what the purpose of that financial transfer was. So something we should be thinking about. Okay, types of complaints that ombudsmen handle. The top 10 in federal fiscal year 2022, discharge and eviction are often, is always the top complaint. And I would just say to you, I know that some of you have been called by a nursing home about a resident who is a problem, a resident who is acting out, and a resident or whatever. So, and they're trying to discharge the resident. We've had facilities call the police to say that a resident was trespassing because they sent them out and the resident came back. And so, or the resident went out to the bar and the facility said, if you go to the bar again, you've discharged, you're not coming back. And so the resident comes back and the facility calls the police and says the resident's trespassing. So those are kinds of things to call the ombudsman about. Response to requests for assistance. And as Nicole was saying, we know residents who call 911 because their call light isn't being answered. I got a call one weekend from a resident I had been working with because she felt she was falling out of bed and no one had come to answer her call lights. And she was, I mean, I was on the phone with her and she was yelling out into the hall, asking for somebody to come. And she said, they're walking by my room. Nobody will come in. I'm falling out of the bed. So I picked up my other cell phone and I started calling the facility. They didn't answer right away. It took many times of me calling for somebody to answer the phone at the facility on the weekend for me to say, there's a resident who feels she's falling out of her bed and her call light is on and somebody needs to go. So I know that you get 911 calls for residents whose needs aren't being met. And as Nicole said, I urge you to take those calls seriously because someone's need isn't being met. If a facility calls you because there's a resident who has done something to another resident or a resident who is being belligerent, keep in mind that chances are that resident has a need, an assessed need, and a need that has been care planned for that the nursing home is not meeting. When a resident is admitted to a nursing home, the nursing home is taking responsibility and making a commitment to provide care to that resident for the federal, Medicare, Medicaid money, and the private money that they're receiving for that care. So I urge you to keep in mind that's a resident who has a need that is not being met. You can see the other types of complaints in the top 10 there. And I'll just say one more thing about the complaints. I already said about 183,000 complaints in 2022. 70% of them were about nursing facilities, 28% were about residential communities and others like assisted living. And then the other 2% about non-facility based services. Ombudsmen verify complaints and attempt to resolve them. We don't have a high burden of proof after the ombudsman does some investigation. Our definition of verified is that after work, the ombudsman has determined that the facts of the complaint are likely to be true. But it doesn't matter. I mean, we can resolve problems that the ombudsman doesn't verify necessarily, issues about shower schedules and that sort of thing. Okay. A couple of things I wanted to tell you about. The facility is required to post contact information for the regulatory agency, for the ombudsman, for the attorney general's office, for a variety of entities who are designed to help residents and enforce regulations in long-term care facilities. So that information should be posted in a place readily accessible to residents and visitors. So you should be able to find it. We were talking about staffing levels and showing up and there being one nurse for many residents. And so if you are getting records about that or you're documenting that, another piece of documentation that would be helpful for you to get is the required staff posting that nursing homes have to have on every shift. They have to say in a readily visible place, they have to say how many residents they have, how many staff they have, nurses, and how many nurses aides they have. So take a picture of that too, because often what they've documented is not going to agree with what you actually see when you're there. Let's see, they also have to provide a list of pertinent agencies and advocacy groups to the residents. How am I doing on time? I have a couple. Okay, I had a couple of examples I thought I'd tell you about where ombudsmen and law enforcement and EMS have worked together. One is, it's extreme, but it has happened more than once. In my state of Ohio, we had an active shooter at a nursing home, a boyfriend who was going after his girlfriend who was a nurse at the facility. He killed the nurse. He also killed the police chief, brand new police chief who responded, and then killed himself. That was an all hands at Pine Kirk Nursing Care Center in Kirkersville, Ohio, one very awful morning. The Attorney General was there, of course, other law enforcement agencies from other jurisdictions were there, ombudsmen were there. What we did as ombudsmen was make sure that we knew where residents were going. By the time the ombudsman was there, EMS was already transporting residents to various places. And so the ombudsman got a record of where all of those residents went and then assisted some residents in finding other places because there was severe damage to the facility that had to be evacuated. And we kept track of those residents. And you talk about trauma and the need for trauma-informed care. We provided trauma-informed care training to the nursing homes that accepted those residents and then continued to visit them. One resident had gone all the way across the state and he was depressed, obviously. Anybody would have been, but he seemed to be especially depressed. And so the ombudsman there kept visiting and visiting, asking questions, talking to him, listening to him, and found out he had a goldfish in the nursing home. Nobody thought to take his goldfish. So we contacted the owner of the building. The building, of course, had been all sealed off during investigation and so on. So we contacted the owner of the building. The goldfish was still alive. So we made sure that that goldfish got from Eastern Ohio to Western Ohio to that resident. So we had an ombudsman went to McDonald's and got it because the shooting happened just before breakfast. So none of the residents got breakfast. The ombudsman talked to me, talked to law enforcement, and they went to McDonald's and got breakfast for the residents and took it to wherever the central command, I think it was a church, where most of the residents went pending transfer to another place. That's not typical for an ombudsman to buy breakfast for residents, but it was an extreme situation. Everybody had to work together to solve this problem and to help those residents. I talked about the 911 calls. We've had other situations where we got called by a facility where, because a resident was moving out saying he was getting married and he was putting this was at an assisted living, and was putting his house on the market. And it turned out he had found online a woman who said she wanted to marry him, and he fell for it. And so so they were able to prevent that. But then later on, it happened a second time. And at that second time, the resident did move. He went to his house. The sale of the home was stopped. And then the second time it happened, he went to his home and apparently with a woman, and someone went to check on them, like doing a welfare check. And I think they found the woman deceased in the home. So it was a bad situation. But another example of ombudsman knowing what was happening in the long-term care facility, and knowing the resident, working with the resident, communicating with law enforcement as things went on. Okay. Just a few resources. We've really talked about these today, so I don't need to go over them. Let's see. I did add a couple while I was listening today. There is if you get a call about a resident or you go into a facility and you see residents with behavioral health care needs, maybe substance use disorders or other kinds of issues, there is now a Center of Excellence for Behavioral Health in Nursing Homes that is funded by Centers for Medicare and Medicaid Services and SAMHSA that was brought up earlier. It's called, they have a website, nursinghomebehavioralhealth.org. They have a lot of training there that's free. They don't consult with anyone other than nursing homes. I'll do one-on-one consultation with nursing homes, but the training is available and free. You can get a newsletter. And then also there is CMS many years ago put together some modules and sent to every nursing home in the country for free, this huge notebook, now it's all online, called Hand in Hand. It's abuse prevention training for nursing home staff. I thought it was great. I put all of my ombudsmen through this training. It has videos and instructor guides and everything. So you can go on to the CMS website and find that. It might be something you could use for continuing education. If you go to qsep.cms.gov and then just search for hand in hand training, you'll find it. I did it earlier just to make sure. Okay. How to find an ombudsman. We have a National Ombudsman Resource Center that is a grantee of the Administration for Community Living. You can go to their website. These are just screenshots. You can click on the map and then you can get all of the state ombudsman and all of the local ombudsman. And then of course, Eagle, which I learned about today. So Eagle's a great resource. Okay. Sorry. I always think I don't have enough for that period of time, and then I just talk and talk. Thank you.
Well, thank you. And so what you were talking about, Ben, is what we're really going to jump into next, which is collaboration and action. So we've heard a lot about collaborating together, and I thought it would make sense to go over a couple of scenarios where we really focus on collaborating on specific cases. And so our first case is an interesting one. This case is one where there's a dispatch call to EMS at 1 a.m. in August, where it's hot, for an injured resident is how it comes over dispatch. The ombudsman is notified, and the assumption here in this scenario, one, is that the ombudsman is on scene to begin with. In this case, EMS finds an injured resident from staff abuse. There are pressure wounds, and the resident is emaciated. There's one nurse on duty at this overnight period. The air conditioning is not operational, and the rooms are overheating. EMS does an assessment, law enforcement arrives, and the ombudsman takes action. So as we go through this scenario, I'm going to ask the three panelists to focus on three basic issues. The first is issue one. What would you do with your team here? What issues does it basically raise for you and your team? The second is, how would you investigate, report, and coordinate with your partners on this particular case? And then the third is, how would you follow up these cases? And with that, Nicole, let me turn to you and jump in on this one, scenario one.
Okay, so this typical dispatch would probably just be a medic unit, which would probably be a paramedic and an EMT would arrive. And their main focus is going to be that patient that's injured. So hopefully our avenues that we have in place, they would call a district supervisor or an officer to the scene from the fire department itself, which would be myself or one of the other 8 jurisdictional officers that are working that evening. So this leaves the medic crew focusing on the injuries of the patient, because ultimately that is our first priority in a case like this. So the district officer on scene would work together. Police are on scene, the local ombudsman's also on scene. So we're going to work together with each agency to address these issues. From my standpoint, what I would do is I would contact my EMS chief, who would also contact emergency management. There's no AC in the building, so they could provide resources and such. Hopefully between the 3 agencies, we can get the state in there, Adult Protective Services. We want to make sure that law enforcement receives the information from EMS, such as the injuries, what the patient has stated, preserve any evidence or anything that we see in the room, trying to not disturb the location. So when law enforcement comes in, either with their body cam or pictures, nothing is really disturbed or touched. As far as our follow-up goes, we would be transporting this patient to the hospital. We would communicate with the hospital. We're also going to make a phone call to Adult Protective Services if we didn't face-to-face with them on scene, as well as the Department of Aging and the Health Department. Um, and then.
And so then we move over to Ron. What do you do next? You arrive on scene. What's next steps?
As far as the law enforcement aspect of this is, first and foremost, we have to know that, we have to put our ego aside and let EMS do their thing first, right? Because we all know the first thing is ambo before cop, so so we're gonna let them do their thing, and because they're more uh, trained in this than we are, but we're also gonna secure the scene, secure the evidence, and make sure that these calls, if they're busy, there's a direct connection line, an after hours line that we can find on our departmental intranet to get a hold of after hours APS and get them on the ball. And the Ombudsman program, they're already there, so we don't have to make that call. And then we'll help EMS assess injuries to get what we call priority, which is like the level of their injury. And if we have someone that's severely injured, then we'll make sure an officer goes with them to the hospital. But yeah, we'll have to kind of piggyback off of what the paramedics are doing, because they're very good at this, and we're just there to secure the scene, secure the evidence, and then make sure everything is documented correctly and where all the victims are going and stuff like that. And then as far as follow-up wise, well, that's kind of where I come in. So once it leaves the officer's hands and it gets into a detective's hands, then they look at all of that stuff, and then I kind of follow up with the detectives and ask them if they need any resources from me. Like if I have contacts within the OAG's office, and if they need help from them, then I can kind of put them in touch with each other. And that's kind of what I do. I just kind of keep things rolling, and I make sure things don't get stalled out. And if they get stalled, then it's kind of my job to help ramp them back up.
And Bev, please, as an ombudsman, what are you doing?
And then the ombudsman is going to visit with the residents, find out if residents have been transported, where they've gone, so there can be some follow-up with them. We want to make sure that they have, if they're leaving, that they have their personal belongings, that they have adequate medications, and their funding. Susan mentioned earlier about many residents have the facility manage a resident account for them that they get from their personal needs allowance. And so that money needs to go with them, and so on. And just talk to other residents. This one resident that was injured, it's possible that others have suffered abuse as well. And so we would talk with other residents and find out what their experiences have been. And then we communicate a lot with regulators, the state health department survey agency, and then would find out if if residents want to go back to the facility, or do they choose to go somewhere else, and what kind of help do they need to find another place to live. And then we are always going to ask if family members have been contacted. Sometimes these emergencies happen, and we'll start getting calls about, I don't know where my mother is, what happened to my mother. And then so we help facilitate that communication. And then something else to know is that every nursing home is required to have an emergency plan that includes an evacuation plan that would have agreements with other facilities, hospitals, and so on. So we're usually going to ask if they have engaged their evacuation plan.
All right, thank you. So now we're going to move to scenario 2. This is sadly a scenario that's becoming more frequent these days, as there's, takeovers in the industry and changes and quality challenges around a facility closure. So in this particular case, the dispatch calls for snowy weather, no heat in a facility with many residents. EMS finds a facility closure and many residents needing assessment and transport. Law enforcement and ombudsmen are on the scene when EMS arrives. State surveyors are also on the scene, and so they take action. And with this one, I wanted to turn to Bev first, but to say that in these situations, we're going to go in order of who would most likely be on scene. But what's critical is that law enforcement, ombudsman, EMS really brainstorm these situations as they happen. This is very close to a real life scenario that some members of our panel here experience. And so Excited to jump into this one. Bev, you can take it away.
Yeah, these scenarios are, there's not a checklist for every possible type of scenario. So it really is important for everybody to just be talking and being creative in how to respond. I've been in a similar situation with no heat in the facility and facility trying to fix an old boiler, and it wasn't going well. And so middle of the night, trying to avoid having residents move, but working with the facility on giving residents, warming blankets for residents. Facility staff went out to Walmart, got gloves and hats for residents and that sort of thing. But we also, Ombudsman also, especially during the pandemic, these relationships were solidified with emergency management agencies too, at the state and local level. And so sometimes the emergency management agency might be able to assist with kind of incident control as well, and so, especially like with weather emergencies and so on. So the Ombudsman would talk with residents, families, if residents wanted to leave, if there were family members who a resident might go stay with temporarily, and communicate that. Again, being kind of a resident liaison while everyone's dealing with staff and facility administration and so on. The Ombudsman have these trusted relationships with residents and then, of course, doing follow-up if residents do move, finding out if they want to go back. Is the facility going to be able to take them back and so on? It is true that sometimes these emergencies result in facilities closing permanently. They decide we're not going to reopen. During the pandemic, we had one facility that told us that they feared that their staff they didn't have enough staff because staff was getting sick with COVID. And so they were going to move all of their residents to two of their other facilities that they owned. And we had serious concerns about that, about the trauma for the residents and so on. And COVID, moving exposed residents to two other nursing homes that didn't have COVID. So we had serious concerns about it. And then, but they said it was necessary, and there was a federal waiver on relocation and so on. So it happened. And then months later, we were notified, well, the renovations are done, so we're going to start moving the residents back. And we said, renovations? I thought you moved them because you didn't have staff. Oh, yeah, that's true. That's true. But we also renovated the building. So we talked to the survey agency and the Medicaid fraud control unit about that as well.
Ron, over to you.
Yeah, so since EMS is there again, we have to kind of tip our hats to EMS, because when there's stuff like this is kind of, we let them kind of take control. As long as we do what we're supposed to do, secure the scene, secure the evidence, we'll kind of curtail off of what EMS needs, and we just have to put our egos aside and just say, you're better suited at this than we are. You kind of tell us what you need and stuff like that. So again, with APS, we would make sure that they're involved in find out where all the other patients are going, and that way we can document all that stuff. And then if somebody from APS or our local ombudsman program needs to follow up with them, at least then I have the report, and I can say, sure, I can get that for you, no problem. But as far as anything specific from law enforcement wise, we would just kind of ride off of the EMS and just kind of, be there for them and whatever they need, and then, secure the residents and secure the scene and stuff like that.
Okay, Nicole, do you?
So as EMS, we do need you. We need you for crowd control is a huge thing, because a situation like this, you're going to have family members coming in, you're going to have other agencies trying to push their way in, not necessarily agencies, but other facilities trying to push their way in if residents are are going to be transported or leaving this facility. Very chaotic situation. So we definitely need you. We definitely need you to give us a hand with some organization. If there's any residents that need immediate transport, such as an injury or anything like that, we'll certainly take them out 911. Our system may be a little different than yours. Our 911 system will not transport privately from facility to facility. The only place we transport to is a hospital or a designated freestanding facility. So with that being said, if someone is going to a different facility, commercial ambulances need to be organized to take them residents out. This is going to kind of fall into a triage mode for us where we have to figure out what residents are actually injured or actually in need of transfer to a hospital for a medical emergency. And then we have to figure out what need that is, and can we just use one ambulance going back and forth so we don't deplete our resources. And just to kind of go off of what Bev said, our emergency management department is run through our fire department, and yes, they can provide multiple resources. So again, I would reach out to my chain of command to have that chief notified to get those resources in there for that facility and get those patients moved out as quick as possible. But I think there's a misconception sometimes that when an ambulance shows up, it's going to take a person from one place to another. But unfortunately, most jurisdictions, most 911 jurisdictions are not designed like that. So it's more of a commercial ambulance. And then that runs into some other avenues, 4-hour waits and that kind of thing. So you may be left on scene to secure some of those things. Resident belongings, things like that, need to make sure we try to ensure if they're not going to go back to that facility because of a closure, we're going to take as much as with us as we can. But if not, we may need you to take it into possession. So.
Yeah, when you talked about securing the scene, it also occurred to me, there are narcotics in nursing homes and lots of other drugs as well. So we've had to take action to make sure that drug carts were secured, building locked up, and so on to prevent theft. Because when somebody knows that something like that's happening and it's happening quickly, there may be people who try to take advantage of that, knowing that there's a lot in a nursing home: belongings, money, drugs.
Thank you. So before questions, we, the panel here, made up of all the different disciplines, want to leave you with really one closing thought. And it's our duty is to give voice to the voiceless. And oftentimes that is residents in nursing homes. They're far away from the center of activity. Nursing homes are not places that we go unless we're visiting a loved one. But these are individuals who may have cognitive challenges. They may not have any family members left alive to visit them. And when you're called on scene, really, to refer back to the previous officer statement this morning, listen to your gut. And if it looks bad, and if there's smoke, there might be fire. And that story about the Hauser case could be going on the other side of the wall. So just think about that when you go in, and thank you all for your comments. I'd like to open it up now to questions. We are rolling down to the end of the day, but there's been a lot presented here. And so please raise your hand if you have a question for us. I have a couple of questions for the panel, so I'm going to ask them if you guys don't have them.
Thank you for the presentation. Earlier, you mentioned unlicensed facilities. Do you run into that frequently, and what are the best practices for dealing with that?
I'm sorry, could you repeat the question about the unlicensed facility?
Yes, ma'am. How often do you run into unlicensed facilities, and what are the best practices for addressing that situation?
Let me turn that over to you, Ron. I think you were talking about that. Yeah.
Yeah, so a lot of times the unfortunate part is if they are unlicensed, unless something happens like catastrophically, we're not getting called there because obviously they're not going to call us. But we do get calls there. And basically what we do is I'll get the unlicensed home, and then I'll send it over to our Office of Healthcare Quality, and then they kind of do their thing. They go in, shut them down, remove all of the patients, and kind of put them into, actual facilities and stuff like that. So yeah, it doesn't happen often because a lot of times it's not getting reported, but it happens more times than you want it to happen. So yeah, there's steps that I do. I usually contact some of the resources in Baltimore County, like even the Department of Aging. They can help out tremendously with giving them resources and housing them and stuff like that.
And just to follow up on that, on these slides, you'll see a consistent theme, which is reporting. Obviously, you are law enforcement, so not, but reporting to the Department of Health, Department of Aging, Long-Term Care Ombudsman, and the HHS OIG hotline, which is provided in the materials. So, yeah.
We have a question over here.
Go ahead.
Just a quick question. We had a nursing home owner who decided he no longer wanted to own a nursing home, and he fired all his staff on the midnight shift. We found out when a doctor arrived about 9 o'clock in the morning. So there was no staff on scene for several hours. We were able to get staff to the scene, but we're still trying to work through the prosecution or possible prosecution because it seems like it's over the head of the prosecutor's office. Is there any federal help or anything that would maybe be in your jurisdiction?
Right, so if I've got your question correct, you had a situation where there was no staff overnight, problems with residents, and did you present this to the state prosecutor?
Yeah, well, they have the case and the Department of Public Health is trying to provide records, but we had about 100 residents without any medical staff for several hours. So
Right.
it seemed like a closure, but we're not sure if there's anything criminal.
Sure. So, there's a couple of things you can do there. I mean, your Medicaid fraud control unit can take a look at that. There could be a failure of care case like I described. It could be criminal, it could be civil. We'll really take a look at that. So you could report that to HHS, Department of Justice, and then we take a look at the facts. I will say that, at DOJ, we take the worst of the worst. So if it's a systemic problem in that facility, it's all about the facts. But I would report it to feds, to state, and to those entities that I just described so that everybody gets eyes on it. You don't want to make a mistake and be too conservative and not move forward. And with that, I think, are we out of time? All right. Well, let me turn it back to Andy, and thank you to the panel. We really appreciate your expertise and your service.